once again on stage to chair this next session. The session will be on Healing Hands, Wound Mastery in Primary Care by Dr. Yasas Abeywickrama, Consultant Plastic Surgeon. Sir.
Good evening, everyone. I would like to introduce Dr. Yasas Abeywickrama. Dr. Yasas Abeywickrama has been serving as the Consultant Plastic and Reconstructive Surgeon at Colombo South Teaching Hospital since 2013. He has been educating regarding pressure ulcer care and wound care since the year 2012. He is the President-elect of the Association of Plastic Surgeons of Sri Lanka. Dr. Abeywickrama is a leading aesthetic surgeon with special interest on body contouring, breast and nose surgery. Over to you, Yasas.
Good evening and thank you very much. And congratulations for the inaugural clinical sessions for the College of Specialist Family Physicians. So we have come to discuss a topic. We should take 3 days to discuss. I got 20 minutes. So what I'm trying to discuss is some of the practical insight into some of the practicalities and some of the basic information that you need to have to be a good clinician who's doing wound care. Can we have the presentation? Thanks. And now everybody is doing wound care. What we have to understand is washing a wound and putting a dressing on that wound is not wound care. Wound care is something that you are doing for a person. We are not, being clinicians, we are not treating a wound. We are going to treat a wound which happens to be on a person. So you are going to treat a person. So that's the most important thing I want to emphasize. And how do wounds heal? Wound may heal by primary intention, that is, there's a wound, it will maybe a superficial burn wound or a small cut wound, it will epithelialize and heal fast. Sometimes it won't epithelialize, it will take time, there's a gap. So there will be granulation tissue. When this, after about 10 days, 14 days, there will be that gap will be filled by granulation tissue and it will contract, and then there will be a scab that will fall off, there will be epithelialization, and there will be a scar. And the scar will contract and the wound will heal. Then in between those things, there are ways to improve the wound outcomes. That's by assisted healing. There's a cut injury, a child coming with a laceration. We can debride the edges nicely and close it, which is called primary closure. If you close the edges just as it is, because when you fall, there's a split laceration. The edges are not very clean. So if you cut them into a clean wound and then suture, that's primary closure. If you close as it is, the outcomes may not be that good. Then delayed primary closure, when a contaminated wound comes, you can dress it, wait for 1 or 2 days and suture. Then a wound may be not good enough to suture immediately, so you may take some time and go for a secondary closure. Then you can get some other reconstructive techniques. We can cover a wound with a skin graft, or if it is exposing critical structures like bone, nerves, blood vessels, joints, or prostheses, or very important functional areas, we can go for flaps which have their own blood supply and good texture. Then excision of a wound and even amputation is another way of closure. None of these things are good or bad. That is why we are treating a person and we have to select the appropriate action. And how do we master wound care? So again, 3-day conference. Actually, with College of Surgeons and SLMA, definitely I think you should invite the College of Specialist Family Physicians for our annual wound care conference, which will be a 2-day conference. Make sure that all of you are there. So, being clinicians, as compared to non-clinicians, you have to know your basics. So it's our job to refer up, read, and I'll give you some insight and where to find them. Then apply to individuals. Don't go on a blanket cover. For wounds, this is the best dressing, this is the best spray. Don't have any preconceived ideas. Go on an individual basis. What is the best thing for this patient at this juncture, for this wound? And have a diagnosis. Please, this is very important. Just treating a wound without having a diagnosis can lead to disastrous consequences, like you may be treating skin cancers. Now, I am very lucky to have had Indira talking before me. I'm sure she showed some of even my photos, the leishmaniasis patients, and some of the skin cancers which have been treated for years as just wounds by non-clinicians and clinicians as well. So if wound is there for a long time, non-healing, especially on an old scar or an old skin graft, think of skin cancer, 4-corner biopsies, or even refer up, because squamous cell carcinomata, basal cell cancers and melanoma are not uncommon in these old scars, which we call them marginal ulcers. And some of these may be pressure ulcers, uncommon area pressure ulcers due to various postural deformities or neurological deformities. Then never judge at looking at the patient, never have a diagnosis which is in the back of your head. Keep an open mind. Maybe on the second dressing, third dressing, you may see, so this is not behaving the way that I want it to be. So rather than blaming it on a bad patient, non-compliant patient, think whether this can be something else. Like always I refer patients to Indira, because we get a lot of patients with inflammatory ulcers, like pyoderma gangrenosum, which is much commoner than that we expect. When they present with a varicose vein, very prominent, we think, okay, this should be a varicose venous ulcer. Now, 2 weeks ago, I had a patient with prominent grade 3 varicose veins, heavy smoker, flushed red patient, nicotine stains, but that lesion was a pyoderma gangrenosum. Then organize your dressing room. Personally organize is as you organize your patient waiting area nicely with a TV and all the facilities, magazines to read, organize your dressing room. Have a special, if you have the space, organize a special dressing room. You can use the same area to take photographs of the patients, even non-wound patients. So have a clinical area for yourself. So those are the small things, but things in the larger print, bold print, I want to emphasize. Please talk to your patients. Talk to them, get the background, why they are coming. You will get half the idea what sort of this could be and what is the impact of this on the patient. Sometimes the patient, like we call hinganna ketuale, the wound may be very important for the patient, not for begging, maybe to get attention. Then, as much as possible, do the wound care yourself. That's the only way that you are going to acquire the clinical acumen and the expertise in wound care. If you get your attendant to do the dressing, then that person is the one who is going to get the experience and the clinical acumen. You will be just looking at the patient and asked to do the dressing, and even you will not be able to tell them, okay, this is not going to work, do this, because they will be telling you, doctor, this is what we have to do next for this patient. So your clinical abilities will never improve unless you do the dressings yourself. And when you do the dressings, make sure that you clean the patient and you apply the primary dressing, then absorbent gauze, secondary dressing, and most of the time a tertiary compressive dressing in oozing wounds. Keep records, maybe on the patient's record or yourself. My primitive way of keeping records, I take a photograph of the wound and I take a photograph of the notes that I write. I've got bad handwriting, but sometimes it's legible. And take good photographs. When I say good photographs, just taking the photographs with all the dustbin and the patient's hand and the all the instruments is not a good photograph. A good photograph should contain what you want to show to an audience. Now, a good photograph will be something that I can put on this presentation today to teach or publish in a journal or compare from the last photograph. So learn about clinical photography. Again, courageous surgeon is having a workshop on clinical photography. Please try to join. It's one of like very subsidized rates, just to recover the food cost. Please join those. Those will enhance your skills and the ability to keep quality pictures, which will help you to be in par with the most of the international population. And once you heal a wound, think that if the cause is there, like diabetes, neuropathy, it's going to come back again. So preventive steps, take preventive steps, and primary prevention even in the other limb. So how does acute inflammation go on? If it is going to heal, there's a wound healing pathway, there's inflammatory phase, proliferative phase, and a remodeling phase, and there will be resolution and the wound will heal. So that's the ideal. We want the wound to heal. But sometimes it can go some other way. There can be pus formation, liquefaction, fibrosis or chronicity. So this is the pathway to wound healing. The inflammatory phase will last about up to 2 days. The wound will happen, the fibrin clot will happen, and the cells will clean the debris. Then in the proliferative phase, all the proteins will come, new vessels will form, the gap will be closed with granulation tissue, a scab will form, epithelialization will start, then it will become a scar. This healing is secondary intention. Then once the scar forms, it's a bit of bigger thing which may elevate larger area. All scars contract. When they contract, it was useful when we were in the prehistoric era. But nowadays, scars, we don't like scars because they cause deformities. All linear scars contract. So if something is crossing a joint or a crease line, they will contract and form deformities. So how do you prevent that? By not allowing secondary intention, that is healing by primary intention, that is getting the wound healed before 2 weeks, especially burn wounds. If it is not healing within 2 weeks, then we go for skin grafts. And the scar will soften up over time and become supple, soft, consistent, will become as a normal skin. But this doesn't happen always. Now, this is the normal pathway. So if it happens this way, like the first cycle, it will go into resolution. But there are so many factors at all these 3 junctures which can disrupt our nice wound healing pathway. So if that comes, the wound can get obstructed in the acute phase, first 2-3 days, in the inflammatory phase, or in the proliferative phase, or in the remodeling phase. Or the obstacles may be in all 3 phases or 1 or 2 phases. That's why you are clinicians, and non-clinicians will not have this ability to decide clinically to identify where the problem is. That's why they will put any dressing the pharmaceutical agents advise them to use. So for you, you will be able to identify where the problem is. The problems can be so many. But But what you have to understand, most of them can be corrected. Now, can we correct age? Yes. You can't correct the number, but you can correct the health and the well-being. So you can make a biologically healthier, younger patient by having a good lifestyle. Ischemia can be corrected. Our vascular colleagues are there. Infection, I'm not going to read everything. So multiple comorbidities, nutritional problems, recurrent injury, all these things can contribute to obstacles in the inflammatory phase, proliferative phase, or the remodeling phase. So in the inflammatory phase, wounds will not heal in like immune problems, anemic problems. In the proliferative phase, your wound will become a chronic wound. It will heal and break down or become a chronic wound. In the all your hypertrophy scars, keloids are wounds which are stuck in the remodeling phase. So how do you help them to get out of that? You can use scar management, steroid injections to go into resolution. So it's helping the patient to complete the pathway of resolution. So there are many types of ulcer. I told you, try to get a diagnosis or differential diagnosis. So infective, neuropathic, then ischemic, neuroischemic, infected ischemic, then inflammatory, like if you remember Indira's lecture, inflammatory immune conditions, cancers, and don't forget that there can be self-injury. Non-healing wounds may be due to the patient doing manipulations or a proxy, that is somebody else who's looking after the patient, manipulating the wound so that it will not heal. So a few examples of the infective neuropathic ulcers are common in diabetic patients, but don't forget there's leprosy, which is increasing at a rate in Sri Lanka, and previous neurological injuries, congenital problems can cause neuropathic ulcers. And then ischemia is relatively easy to identify, and but the challenge is to identify them when they have claudication and not having ischemic fingers. Then ischemia with neuropathy, and ischemic wounds which are infected, and it's very important not to do wound toilets in ischemic wounds, because if you do a wound debridement, it will become ischemic again. So in those patients, it's better to refer to vascular opinions and get them to do some improvement in the vasculature before debriding. Otherwise, you will be just debriding up until you get to the skeleton. And so this is Indira's area: inflammatory ulcers, skin cancers, Kaposi's, sarcomas. There can be so much of it. So always keep an open mind when you see your ulcer. And this is something I want you to know: how to prepare a wound bed, either for healing by secondary intention, epithelialize and close the wound, or to get a wound fit for a cover, assisted closure, like a skin graft or a flap. And this is called the time concept. There are two components: general care of the patient, correct the general condition, etiologies, then prepare the wound bed to optimize the wound to either heal by itself or accept a reconstructive technique. So general care, correct general conditions. If we identify treatable causes, treat them, like diabetes, anemia, hypoproteinemia, then improve vascularity. And recurrent injuries, like if somebody is walking on a neuropathic ulcer, if you offload, sometimes even without dressing, this is going to heal. And offloading can be done with special footwear, or what I do is just after my dressing, by plaster, I attach a gauze roll on the front and the back of the ulcer. So the patient, even if they want, they can't walk on my ulcer. So these patients heal very fast. And there are no magic dressing type. There's no special dressing which is going to heal all wounds. Sorry for the spelling mistake. Sprinting, then improve nutrition, you can improve sensation. Sometimes things like tarsal tunnel release can be done, and taking steps to prevent further damage. And this is the time concept. Please take a photograph of that. Go and refer time guidelines. This was put up in 2003, and in 2012 there was an update, and it's been constantly updated. There are very nice YouTube lectures. Listen to them. You will get an idea about how to look after a wound. This is a very nice concept. It's called time. It's tissue infection, moisture balance, and epithelialization. It was only that earlier. Then later on, they added this other things like peri-wound maceration, then cost-benefit issues, holistic and systemic evaluation, then handling the patient environment, handling the treat healing environment, and the available therapeutic device. Like what you do with sophisticated dressing can be done with saline soaks in a peripheral hospital without any facilities. Only thing is going to be more nursing intensive, because you have saline soaks you have to put at least 3 to 4 times a day. But we can't complain that we don't have sophisticated dressings. I think battery is down. Next slide. Slide before. Oh, yeah. Next slide. Thanks. Yeah, next one. Yeah. So there's a big document, long document, complicated. So I have summarized what is there in 2003 and 2012 documents into 4 slides. This is tissue, necrotic tissue. Remove the scar necrotic dead tissues by surgical or non-surgical means. There's no need to go for repeated wound toilets. Debride and then go for surgical, non-surgical debridement with, like you can use many things like saline soaks or hydrocolloid dressings. Then what you do is early wound cleaning and reduce the bacterial load and get the wound prepared for to either heal or uptake a cover. Next slide. Then infection. It can be acute infection, chronic infection. Acute infection, very easy to identify: calodolo, rubor, tumor, and loss of function. Chronic wounds are difficult to identify. So chronic wounds may present some of the features, maybe increased discharge, delayed healing, wound breakdown, collections, pain, dull, deep pain, abdominal granulation, discolored wound bed, or malodor. These may help you to identify infection. It's very difficult to identify infection in small children and elderly. And some of the topical antibiotics you can use are cellular dressings, iodine dressings, modified honey dressings, and polyhexanides. All these are available in Sri Lanka. But the simplest low-cost dressings of rotational antiseptics, what I use is 1% acetic acid for soak for 15 minutes, wash it off. Then I alter with hyperonic saline and povidone iodine. Sometimes you can add silocyberdazine as a rotation. Milton also is being used, hypochlorite, but I don't use it personally. Then moisture balance. Ideal environment for wound healing is a moist, dry environment. So that seems contradictory, but moist is, it should not be desiccated. Dry in the sense it should not be waterlogged. So in a dry wound, you use water retaining dressings like gel dressings, foam dressings. In a dry, more moist wound, exudating wound, you put a lot of absorbent dressings. Negative pressure suction will do both. And objective is getting good moisture balance. Edges is epithelialization and edges. So wound, if it's healing, we allow it to epithelialize and heal. But also we can go for skin cover. So debride, get the wound to epithelialize. We can use adjuvant treatments like negative pressure, ultrasound, laser, hypobaric, but not essential. So this is time in action. This is one of my patients, breaking of cesarean phanestoid incision, initial debridement, tissue, then infection, rotational antiseptics, and moisture balance. And then we get a clean wound without infection. We apply the negative pressure suction. It improves vasculature, makes the wound smaller, and then we went for closure. Another example, with tendon and bone exposure, rotation antiseptics, then negative pressure action, granulating wound, small exposures, then we graft on it, and those small wounds were healed by secondary intention. There's a group of patients we are not going to heal. The objective is not to heal them. We are not going to heal, we are going to just maintain status quo, and these are the palliative patients, the patients who are not going to make it. We are not going to do any heroics, just manage pain, manage discomfort, make sure there are no maggots, no discharge, all the absorbent dressings are applied, no bleeding or malodor, so they can spend the little time they have with the family and leave good memories with the people who are there, and to accept the loss of the patient, that keeping in mind that they died peacefully. Thank you very much, and remember time, and go and read it. Thank you very much.
Thank you very much, sir, for that elaborative and session with examples. And that was, ladies and gentlemen, Dr. Yasas Abeywickrama, consultant plastic surgeon, who did on healing hands, wound mastery in primary care. And I cordially invite the chairpersons to hand over the token of appreciation and certificate to Dr. Yasas Abeywickrama.